That's not so great. But if you look at patients over 65, it tells a different story, right? Here, it's actually a number needed to harm is 11. You only need to treat 11 people before you harm them. And the number needed to treat is 64. So there, in these older patients, thrombolysis definitely doesn't seem like a great idea. But in younger patients, the numbers flip completely. So now, you're more likely to help someone than you are to harm them. So again, you can select the right patient population, low risk, young people who are less likely to have intracranial hemorrhage, more likely to die, that you can treat with thrombolysis, right? Okay. Now, there's also some studies looking at low risk, or some people call safe dose of thrombolysis, okay? And this one is called a Moffitt study, and basically they said, well, we're going to make up our own definition of moderate risk, not the same one that ESC uses. People like making up their own stuff. But it was an interesting study because what it found was if you gave just half of the dose of thrombolysis instead of the 100 milligrams, which is a reasonable question because in fairness, the 100 milligrams was kind of made up back in the 90s, right? So why not make up 50, right? So now we have 50, and in fact, nobody had bleeding. Okay, and outcomes were better. But this study was very strange. It didn't use standard methods. There's a lot of questions about this study, but it did get people thinking, right? It got people thinking maybe 100 milligrams is a lot, right? And so there's the possibility of treating this patient with IV thrombolysis, but maybe half dose or something small. Okay? But as we talked about, there's some other new therapies. And I'm going to run through these fast because we've got that third case I want to get to, which I think is an important point for all of you. Here, there have been a handful of trials that have all shown kind of the same thing. Okay? Only one of them in catheter-directed thrombolysis has ever been randomized. That's this one. It's small, 59 patients. It's not 8 patients, but it's still not a big trial. Okay? This one showed that if you treat intermediate risk PE patients with thrombolysis, you will reduce the rate of right heart failure, and you will reduce the clot burden, but it didn't show an improvement in mortality. Okay? Seattle 2, this is not a randomized trial, this is a registry. And again, remember when I told you that early study of urokinase showed decrease in the amount of clot and decrease in the amount of right heart failure? This same model has now been used in all of these other studies. So, not necessarily looking at mortality, right? We're looking at physiologic measures. And again, decrease in pulmonary artery obstruction, decrease in right ventricular to left ventricular ratio, decrease in right ventricular failure. Okay. So maybe catheter-directed thrombolysis helps. Here's another study. This is called the Optimize PE study. Same thing, catheter-directed thrombolysis, but this time they use different doses. The way catheter-directed thrombolysis works is you feed a catheter in, you put the catheter into the clot, or right next to it, or right behind it, and you run thrombolytic right into the clot. The theoretical advantage is that because you're putting the thrombolytic into the clot, you can use a much lower dose. Even the highest dose of catheter-directed thrombolytics is about 24 milligrams, which is 1 milligram per hour through 2 catheters in each side of the heart. Okay? Compare that to systemic thrombolysis, which is 100 milligrams in 2 hours, or sometimes even less. So you can imagine a lower hourly dose of thrombolytic given over a longer time may be more effective and should reduce the risk of bleeding. That's the theory. Okay? And the idea that you're putting it right into the clot as opposed to everywhere in the circulation should reduce the risk of brain hemorrhages and GI bleeding and things like that, although that may not be true. So in this case, they actually studied different doses of that approach, and again, found that the amount of clot was reduced in 48 hours. That's nice. The amount of right ventricular pressure was reduced in 48 hours. That's nice, right? But again, it's not showing an improvement in mortality. And one of the things we also see with catheter-directed thrombolysis is that, yes, there's an improvement in 48 hours, but if you wait 30 days, the people who did not get thrombolysis have the same improvement. It just takes time for their hearts to get better, but eventually they do. Okay? Different catheter, same results. Decreased right heart function, decreased clot. You see this over and over and over. But again, we think this is going to be associated with a lower risk of bleeding. And so we look at this and we say, okay, in Seattle 2, there really was no intracranial bleeding with catheter-directed. That's nice. In other studies, again, low rates of bleeding, but not zero. Okay? All right. Overall, if you look at meta-analyses comparing catheter-directed thrombolysis to either anticoagulation alone, you see improvements in mortality and 30-day mortality. But again, these are meta-analyses of not randomized controlled trials. These are meta-analyses of registries. So you have to take these data with a little bit of a grain of salt, as we say. Right? Same thing if you compare catheter-directed thrombolysis to systemic thrombolysis in these intermediate risk patients. Looks like there's a change in mortality, again, based on non-randomized trials. Right? And it looks like the bleeding risk also favors catheter-directed thrombolysis. So far, so good. Fortunately, there are at least 2 trials that are currently enrolling. One is funded by the NIH, National Institutes of Health. One is funded by Boston Scientific, who makes one of the catheters. You decide which one you like better. All right, I'm actually on